I'm a pulmonary critical care physician at the University of Texas. I'm the director of the Division of Critical Care Medicine, and I'm the executive medical director for critical care at Memorial Hermann, one of our partner hospitals, and the assistant CMO there. So I'm actually going to start off with a story. So when you look at a clinician's perspective of what the problem with our current system is that we don't actually get a story. It's really difficult to put discrete data elements into a story. We spend an enormous amount of time putting those patterns together. So Little Red Riding Hood, I'm sure everybody recognizes this picture, you didn't know this, but she's a critical care physician. And in that basket of life-sustaining devices or nutrients, in the story it was muffins, but in my world, it's antibiotics, vasopressors, ventilators, whatever it is, for life-sustaining devices for grandma who is perhaps has sepsis. And so what is sepsis? So being in the critical care environment, I would say the 60 to 70% of our unit and our medical intensive care unit is sepsis, and we deal with this all the time. So I'm sure most of you are aware of what sepsis is. But for those who aren't, it's really a body's response to infection. And when that response goes into disarray, you have multi-system organ failure, you can have shock, and you can have death. In fact, there's a 30 to 40% mortality across the board. It's the most common cause of death in the ICU. And early intervention, we know, can decrease mortality for up to 25%. And I think that's one of the key areas of focus for us was sepsis and the decision support around management and detection of sepsis, because just by simple techniques of early detection, early intervention, and effective intervention, we can actually improve mortality, and very few things can you do that adequately. So the problem with detecting sepsis is what the Red Riding Hood had. She saw the grandmother. She saw something that would look like her grandmother because it had two eyes, it had big ears, it had nice teeth. And that's really the problem with detecting sepsis, is that it's really hard to put the whole picture together when it's cloaked behind the bed sheets or cloaked behind pieces of data elements that are hard to come by, or you have to look for them in multiple places. So it's a difficult diagnosis because you have to put the story together. And so what did Little Red Riding Hood do, or what could she have done? What kind of clinical decision support tools were available? Well, we started off about a decade ago with using simple clinical decision support tools, right? The checklist, the screening tool. So for Red Riding Hood, clearly, checklist for figuring out whether it was a wolf or not. Did the wolf have big eyes, big ears, sharp teeth, and so forth? And for sepsis, we used did the patient have a white count, fever, respiratory rate, and so forth. And so clearly we recognized that we did a poor job of recognizing sepsis. That's why we had to develop these crude tools and then started using them in a systematic way. So initially, when we worked on this screening tool, this was 11 years ago when all the sepsis interventions by Manny Rivers was getting published in the New England Journal of Medicine. So we started screening on admission. We wanted to make sure we didn't miss sepsis on admission. And so we asked the nurses to fill it out. We asked the residents to fill it out. And so it was fine for early detection in the ER, perhaps, because sometimes the whole picture wasn't there. It wasn't really applicable to elderly patients because the picture may not be synonymous with routine findings and so forth. But then we realized that what happens if they develop sepsis in the hospital or their sepsis worsens? So we started using it more and more often. We started looking at it every day. So the nurses and the residents filled out the screening tool every day. And then we said, well, that still wasn't effective. So we started doing every shift. And so clearly we understood that wasn't effective because you can't detect the wolf, which is clearly sepsis, every 12 hours. You constantly have to understand where the wolf is, if it's there, what state it's in, and what you need to do to intervene. So, like a lot of systems and companies, we actually at Memorial Hermann have a Cerner partnership, And so we implement Cerner's St. John sepsis tool, which is exactly that. It's a screening checklist that goes through continuous crawler, iCloud methodology, and continues to crawl data in the cloud. And whenever the parameters are met, it alerts us. And so we thought, wow, what a great tool to have a continuous alert system. So our paper order sets went away. And we still continue to implement this across systems, are encouraging buy-in, because what happens when the alert goes off? Who gets the call? Who's looking at the data? Who does the intervention? We have it implemented very well in some hospitals, but struggle at other hospitals. But here's the problem. So just like with Little Red Riding Hood, you know that the patient had, and grandma and the wolf, have 2 eyes, 2 ears, teeth, legs, so forth. And same with the St. John sepsis tool, or any sepsis screening tool, is that it gives you the data elements to trigger your concern for sepsis, but it doesn't tell you the story. And this is where we were. We had numerous calls, hundreds of calls a day across the hospital, telling the physicians, your sepsis alert went up, your screen is positive. The problem was, we didn't know what the story was. And so then it led to a lot of frustration, because the physicians are constantly having to go into the electronic medical record, click, and I counted one day 42 times to get the information I needed. And then it started the intervention process. If you weren't at the computer, you were constantly asking the nurse for pieces of data elements that they may or were not aware of, and it took them even longer to get the data to you. So it was really frustrating. And figuring out what this was wolf or grandma was the biggest issue. So anybody know what an ICU flow sheet looks like? Okay, so I'm sure a lot of you know. Since I've been practicing critical care for a while, before when everything was on paper, this is a flow sheet in the ICU, and it's a simple tool. It used to be, when I started, it was 3 pages, and this was a 2-page version. And it documented everything. Blood pressure, its relationship to heart rate, its relationship to cardiac output, to mean arterial pressure. If I wanted to know what the urine output was, I just looked down. It told me the urine output. If I wanted to know how fever was associated with the tachycardia, I could look right there. It was a relational picture. And I could go by every ICU, pick up the sheet of paper, and know exactly what was going on with my patient at all times. And the nurses noted when the patient was turned, they got hypotensive. There was quick little squibbles everywhere. And I wanted to know the laboratory data. I took a quick flip back. And within 15 seconds, any intensivist could look at the sheet and figure out what's going on with the picture. And that's what we were missing. So that's why we had partnered with Trevor and Khalid El Musa and tried to develop a model where you could have that information, that relationship model in real life. So when an alert goes up, whether it's a paper alert or electronic alert, what data elements do we need, and what relationships do we need? And what are we looking at? So, for example, this is some of the screenshots, and I'm sure Trevor Cohn will be talking about this further in a little while. But basically, the SIRS alerts goes up. It gives you relationships, time elements, and then you can look at organ systems. How did it relate to, if the patient's hypotensive, what is the renal function, what did it used to be? How does it relate to the cardiac output? How did it relate to the altered metal status? What about this cardiovascular system? What data elements do I need? And so it was a concise tool of everything we needed to manage sepsis, and data elements that were put into relationship context, both time and within each other, to really make this conversation either between the nurse and the clinician, or a quick access to the clinician of information that were within a few clicks away, not 42 clicks away. And again, this is a demonstration of some of the screenshots, which we'll talk about, but Dr. Cohen will talk about in a little bit. So here's the next step. So we've talked about early detection. We have initiated development of the data elements we would need to determine whether this was really a wolf or whether it was grandma, to really understand sepsis and understand the snapshot relationship of all the organs and as they're dysfunctioning. But what's the future look like? Well, what we don't have is how are we going to initiate, how effective are we at initiating management? So, for example, this is the early goal-directed therapy flow diagram from Dr. Rivers' article in 2011. And clearly there's an algorithm that needs to be initiated. And it has to be initiated and completed within 6 hours. And generally, the faster you get it completed, the higher your survival in general. So, but we don't have that. We actually don't know how to improve outcomes unless we're doing individual data collection. And so we don't know how long it takes us to get to CVP target. We don't know its relationship to the cardiac output and heart rate and so forth unless we're looking up each individual data elements. So the bottom didn't show up, but so these are our sepsis bundle elements, which include, do we get to our CVP target? Do we make sure that the patient got their antibiotics and so forth? Everything within the 6-hour time period. And when we started in 2007 to really look at how effective we were all over the place on individual patients. And it took us years of getting to a steady state. And so, and we continuously struggle with this. We hand collect data just to look at how effective we are. So what we really need is to make grandma survive. This is NASA mission control, and I was actually there 2 weeks ago. And I was fascinated by how they were monitoring the astronauts' vital signs. They knew exactly what was going on, what their heart rate was, their temperatures and so forth, and what activity that they were doing, and they could easily, through 3 snapshots, make clinical sense out of everything that was happening to the astronauts in the space station. So wouldn't it be great if our decision support tools, or not great, what we really need is decision support tools that actually help us be more effective in management. And so, for example, in sepsis, how long did it take us to detect sepsis? Were we delayed in the ER? Were we delayed on the floors? And once sepsis was detected, how effective were we at getting antibiotics into the patient? Fluids, how much do we give? How long did it take us to reach target? What about organ stabilization? How long before we could perfuse those organs? What about urine output and other types of organ dysfunction? And even more importantly, as the patient survives, you have to de-escalate pretty rapidly and de-escalation. So they're all time relationship observations. And all this data is clearly available. It's all in our Care 4. We look at it as discrete data elements, and we look at it every day. And we struggle with this because we hand collect this data, put it into graphs, and to make sense of it. And it's quite frustrating as a clinician to know that this could be easily displayed in a very visual format, know hour by hour, minute by minute where we are in the resuscitation, and knowing and that visualization can improve our resuscitation and improve survival. So this team can actually be the wood chopper. It's really the carpenter wood chopper who came to save Little Red Riding Hood and got rid of the big bad wolf. So you have to save grandma. And how are we going to do that? It's great that we've come a long way. We've gone to 2 steps. But really we need prevention systems. How do we prevent sepsis from happening? Have we ever thought about that? Do we look at how long our central lines have been in, what the indications for Foley's and so forth? Early detection systems, I think there's lots of companies that have started looking at that. And I think we've come a long way. We still have some improvements to make in that area. Early intervention systems. The earlier the time to treatment and time to treatment goal efficacy and organ system stabilization, without that, we still struggle about how to manage these patients. And then organ response systems. And finally, de-escalation systems. So we've just started looking at this, and this evolution of clinical decision support, I think, will be extremely important if we're going to continue to improve mortality in the critical care environment. Thank you.